which is like a big issue right now, and radiologists and technologists get involved a lot as a part of the care team. So we want to learn how to adjust the imaging technique, get a proper image quality to get the correct diagnosis to the patient from you.
Yeah. All right. I assume you can see my screen now?
Yes.
Perfect. Off we go then. So everything I just said, throw it out the window, right? We're now imaging in the most unideal circumstance possible. We're not bringing the patients to us in radiology. We're not putting them on a table. We're not putting them standing up against a wall bucky. So the grids are not going to be perfectly aligned. Our technique factors aren't going to be the same. We just have to work with what we've got. So this is where both the technologists have to do their best to get the best image, and radiologists have to be the most flexible to look at images that just aren't really going to be that ideal. So what are the goals here? Well, actually, let me step back. What are we basically doing? We're doing mobile imaging, right? So these are patients that are sick. They're in the ICU. They're potentially not in a place where, even if they weren't that sick, you still don't want to bring them to the other part of the hospital where they could potentially infect the staff or any of the other patients in a different part of the hospital. So we are going to be imaging in a very unique location. Oftentimes these patients are in isolation, especially if they're in the COVID ward. And the patients may or may not be able to move. They may not be ambulatory, or they may not be able to even speak. They may be intubated. And so we might not be able to give them communication, talk to them, like taking a deep breath and hold. All of the stuff that we typically do in radiology, in our main part of radiology, we will have to adjust. And then, of course, unfortunately, we're dealing with a lot of sick people right now. And so we're talking about space being limited. You've seen a lot of the news coming out of India, where, I mean, it's not only are they so busy, it's that they're maybe sharing beds. You might be going to image someone and there might be two people in that bed. And so highly in the most unoptimal situation possible. So what are the goals of imaging for COVID? To create the best possible image for the best possible patient care. We understand that, right? 2, we need to stay operational. You, the technologist, can't get sick and go home and have COVID. We don't want that. And 2, we can't contaminate our mobile unit, our detector, because if it gets contaminated, then we can't take it to the next patient because now it's a hazard. So we got to keep you safe, keep the machine safe, keep the detector safe. And then obviously we need to be flexible. So why do we image COVID patients? It's often been asked, especially when it all started. We immediately saw people taking x-rays and CT scans, and we could see the ground glass. We could see the opacification, the pneumonia-like look in the images. But the reality is that imaging is actually not recommended for the diagnosis of COVID. And that is just because COVID pneumonia looks like basically all other pneumonia. In fact, CT and X-ray, neither of them have shown to be any more specific for COVID. And a publication that came out, of course, in 2020, there's a lot of publications that have been looking at this. They looked at what was that cruise ship? The Crown Princess, I think, that was out, and it was one of the first that COVID got there, and I think 112 patients were COVID positive on that cruise ship. No, actually, I think there were more. There was many more, but 112 of them got CT scans. 61% had lung opacifications, so they had kind of that ground glass, that pneumonia-like look. 20% had negative CTs, absolutely clean-looking lungs, but they were symptomatic with COVID. And so the take-home message from this was that imaging wasn't specific enough to determine that this test could diagnose COVID or rule out COVID. So why do we image? We image mostly for the management of patient disease. So we're looking for progression. we're looking for potentially all the other comorbidities and side effects that come with COVID. And so we have to be, we're not necessarily just imaging for pneumonia. We're actually also imaging for line placement. We're imaging for a lot of other things. So yeah, there we go. That's what I wrote. Okay, well, I'm sure you've seen these by now. If you haven't seen them in the literature, you've unfortunately probably seen them on some of your patients. So what does COVID look like? Well, it looks basically like pneumonia. You got disease progression where you got fluid buildup in the lung parenchyma, and this just becomes with time more attenuating. When you got fluid in there, it's not air. So you get more photons that'll attenuate. And so you got this fluid-like or attenuation-like patterns throughout the chest. So what is the goal? As I mentioned, we're trying to do our best to help the patients get the best images for our radiologist so they can work with their colleagues in the ER or in the ICU. But the reality is we can't get you, the technologist, and the machine exposed. So one technique that was developed very early on is what we call image through protocols. We are going to quite literally image through glass doors. We're going to image through doors with teeny little glass openings. We're going to image through whatever we can image through, right? If we're lucky, we might image through an open door in a negative pressure room. So, and this is probably the most ideal situation because you're not actually going through glass, but it's not ideal because you're still shooting outside. You're in the ante room, you're over here, whereas the patient's in the negative room, in the actual room where the negative pressure is. It's obviously allowed to have an open door because it's a negative pressure, so the air is only flowing into the patient's room and not out to you. So those are kind of the three major areas or three major geometries in which we're going to image. So let's talk about the patients for a moment. How can we image them if they are ambulatory? So they can get up, they can move around, and obviously that means they're not intubated. And that means we can most likely talk to them. So what we're going to have them do is we're going to have them stand up. Sorry, it's rolling the wrong direction. I'm going to have them stand up. They're going to come to the door. So we're going to image through the door. We're going to have them turn around. So we do a nice typical PA acquisition. And we're going to have them hold the detector. So no chest bucky in the room. They themselves are the chest bucky. And we're going to do our best to get that detector lined up to the chest anatomy. The other option is wheelchair bound. So they're still, maybe they're not intubated, so they still can maybe communicate, but obviously they've progressed enough in their disease, or they physically themselves just cannot stand because maybe they already are physically disabled. So they're in a wheelchair. In this case now, we're going to move the wheelchair once again to the door. We're going to get it close to the door, where they'll be seated upright, and we can put the detector directly behind them, between them and the wheelchair, and we can acquire the image. And then in the worst case scenario, these patients are going to be confined to a bed, potentially intubated, and so you will physically have to take the machine into the room. There is just no other way to get in and position it and image down over the patient while they're laying on the table, on the bed. So the first two, as I mentioned, we're going to be imaging through a door. The other one, we're going to be imaging like you always image mobile units. So we do not need to make any we don't have to make many modifications for the last option. Okay, so let's go through these in a practical sense. So one of the best things you can do is you're going to be working closely with the other staff that are in the room. So this is the scenario where you are not going in the room. You're going to have to help instruct the nurse or whoever else, the support staff that's in there working with the patient. So the first thing you're going to do is you're going to take your detector and you're going to cover it in a sterile bag. Some publications, such as the one I quoted here, they actually covered it in 2 bags, just in case the first one got accidentally perforated. That's just, you want to minimize how much this detector is going to be directly exposed to a COVID environment. And that helps you, and as I'll explain in a minute, that prevents you from using a lot of harsh chemicals to clean and sterilize your detector. So we're going to bag it, and then we're going to hand it through the door to the nursing staff or whoever else is in there. You're going to then work with them, and they're going to help give instructions to the patient so that they can come up to the door, and they're going to turn their backs to the door, and they're going to hold the detector to their chest, as I mentioned. Where, if it's possible, I highly recommend that you actually put markings on the tape on the floor. Now that's going to be difficult because if you put tape on the floor, your infection control group, they're going to be cleaning those floors all the time. That tape might get ripped up. If you physically mark on the floor with like a physical marker or do anything permanent, well, it's going to be there forever unless they fix the floor. But the reason I say if you can put a marker on the floor is that we talked about knowing where your distance is. And if you're shooting through a door, you can't actually take the measure. You got the collimator. You can't take the measuring tape out and go check to see how far away they are. You can only guess. And so if they're staying at a mark on the floor that's set at, say, 72 centimeters or, not 72 centimeters, 72 inches. So, about 140, 150 centimeters, then you know what technique to type in. And then you might need to put multiple markers on the floor because it's in a perfect situation, they can come up to the door. So you can keep your SID as short as possible. But if they just physically can't, or there's a lot of stuff in the way and they may be farther away, well, what is the source? What is your SID? You don't know. But if you have a couple of markers on the floor, you might at least be able to go, oh, they're about 200 centimeters away or 220 centimeters away. So you can make that guess and you can adjust your technique accordingly. All right. So if they're in the wheelchair, we already kind of talked about this. You can just place the detector behind them. And in most scenarios, they probably going to be in a bed. Once again, they can be wheeled up to the door if possible. Detector, it's bagged, placed behind the patient. As much as possible, we're going to have them sit upright. The nursing staff will place it, but obviously the nursing staff will then step back. We don't want them holding the detector if they don't have to, because we don't want to be exposing them. All right. Now, we are imaging through something, so we have to change our technique. We have to image through glass, and we have to image through distance. We're changing the SID. So the SIDs can actually vary quite a bit, anywhere from 180 to potentially 500 centimeters in some publications I read. So you got to image across the room. That's crazy. You also need to know where you're aiming, right? And so for us, we have the collimators and we have the light fields. So we're going to need to be able to, whoops, not that button. My apologies. Sorry, I pushed the end button, not the next button. Okay, so we need to be able to see the collimator as it's projected on the patient so we can set our collimation as best as possible. And then we need to talk about grids. All right, so the technique factors. Normally, we're shooting, Tanya and I, we just talked about this. Normally, you're shooting around 100 kV, about 2 to 4 mass when you got the machine right next to the patient. You're not shooting through glass. This is what we would do in an ideal situation in, say, a fixed room. So their patient's up against a chest bucky. This is kind of what you're shooting at. If you're in a mobile situation where the mobile goes into the room in a non-COVID environment, this is kind of what you're doing. So we need to modify that. You're going through glass. So we absolutely have to increase the kV. We have to penetrate that glass. And so you're going to start right around probably 120, 125. You may even have to go a little higher depending on if it's thicker or older glass. I just don't know what your hospital's like. Unfortunately, it might be a little bit of, you might have to just trial and error that. If you have phantoms and stuff, maybe you could do some pre-testing, but this is probably happening in real time. So the first patient you wheel up to them, you're going to line it up, and you're probably going to just change your KV up to 125. And if the image just doesn't look good, you might have to go up a little higher to 130. Now, like I said, some mobile units will actually have filtration in their physical filters. You can either physically take them out of the collimator, or there's a button that will remove the filtration in the collimator. I recommend taking all that filtration off. Turn it off, because the glass itself, the window, will be a filter for you. And so if you have a filter in with copper and aluminum plus glass, then you're really going to have to crank up your technique factor. And that's just not good. Obviously, it's more dose to the patient, but it's a lot more scatter for everyone else. So too much filtration will reduce contrast, and we talked all about that last time. Changes the KV, changes the mean spectrum energy, changes scatter. So typically what's out there in the literature, typically what you would use is somewhere in the 120 to 130 range, and you're probably going to be about 6 MAs in time. You might go a little higher, 7 or 8, depending on the size of the patient and your distance. This is if you can get them up to the door. Now, if they are farther away from the door, the only thing you can do is increase your mass. Because remember, as you're imaging, as it goes away from distance, 1 over the distance squared, your photons are changing with 1 over distance squared. So you're getting less and less as the distance gets farther and farther away. So you have to compensate by increasing it by a couple of steps. So there's a couple more things. And now, this was the question that was asked a little bit ago from our friend in Vietnam. He mentioned that what happens if we tilt it a little bit? Well, I said, do your best to keep the detector and the radiation beam perpendicular. Like I said, that's a perfect scenario. In this case, this door has a very small glass window, and a patient is not going to be that tall. At best, if they're standing, they're going to be shorter, so you're going to still have to come at an angle. At worst, they're going to be sitting in a table or on a stretcher, or they're going to be in a wheelchair. And so your angles now are not perpendicular. You're coming in at this weird angle. And because of that crazy angle, what can you do? There is nothing you can do. So your images will be off angle. So what does that mean? That means the anatomy will be distorted in the image. It's very helpful if you maybe make a comment on that to the radiologist, so they just know that image was at angled high or something. So they know that they're basically looking down at the anatomy, not straight onto the anatomy. Those are all things I already said. Oh, this is actually a good point I should make. So when you're imaging through the glass, you, as I mentioned, in a typical situation, you might be 8 MAs or so. You might go as high as 10 or 12 MAs. The problem with these portable systems is you actually don't have that many MA options. You might be able to dial in 1.2, 2, 2.5, 3, 3.54, 5, 6, 8. So as you get higher in MA, the options become fewer and fewer in between. There's bigger jumps. So therefore, if you want to go from 8 MA to 12 MA, you actually might not have that option. And so what the system does is it increases the amount of time the machine is on. So you still can get a 12 MAs, but you won't get a 12 MA. You'll actually get maybe like a 8 MA for that much longer of time, if that makes sense. So the problem with that is the longer the beam is on, there is a lot of obviously motion going on. They probably can't hold their breath. If they can hold their breath, that's great. But if they can't, there's involuntary motion. You got cardiac motion, you got lung motion. If the people are sick and they can't stand as well, or if they're, even if you sit here perfectly for a minute or two, you'll just kind of fidget. People just don't normally sit still for a very long time. And so the longer the exposure time, the greater chance for motion artifacts. And unfortunately, once I get said, there's just not a lot we can do about that. So the other thing to talk about is being able to set the field of view. So we just talked about getting the right collimation, right? Well, you need to make sure you at least get the right anatomy. The right anatomy is the lung field. And so what we're going to do is you need to set the lights prop as best as you can. And so if you can't, when you turn on your collimator and you start adjusting it, it's projecting through the glass onto the patient, you may need to ask them to turn off the room lights so you can get a very good idea so you can set it. Worst case scenario, if you just can't turn off the lights and you're in these really high bright light interventional rooms, then what you'll have to do is just open up your field of view. And that is why a lot of the COVID images they have your lungs, they got the lungs, and that's good, but they might include a lot more of the human anatomy. It is what it is. So the image quality will come across. It won't be nicely mapped. The blacks, the whites, the grayscales, they won't be as nicely mapped, but it is what it is. Now, I mentioned grids. We want to use grids as much as possible. But if you're coming in at weird angles, the grids potentially are going to clip the data. And you don't want the data, you don't want the anatomy to be clipped because it will burn out, the lung fields, or you'll lose some of the imaging along the periphery of it. So, and then I guess the other thing to consider, especially if you got a heavy grid and you, the technologist, struggle with that, you're not going to be able to get a patient to hold a heavy grid either. They'll hunch over, especially if they're sick. So there are real examples of when you probably will not be able to use a grid. In a perfect world, you will still do your best to get the tube as aligned as possible to use the grid because you'll get better image quality. But if you cannot guarantee that it'll be a good perpendicular, or if the grid won't really stay attached, once you put it in the bag and there's the potential for the grid to come unseated from the detector, or if the patient themselves has to hold it and it's hard for them to hold it, then you're just not going to be able to use a grid. Now, if you are going into the room and placing it under the bed, under the patient, then you can still do a grid. If they're sitting in a wheelchair and you're putting it behind their back, you could probably use a grid as long as you can get that as well positioned as possible. So do your best with the grids. So let's talk about how we've really talked a lot about the negatives here, right? We've talked about how we have to increase our kV to get through the glass. We've talked about how we've got extended SIDs, but there's actually some positives in this. First of all, we have to increase kV, but because we're imaging through glass, the glass is a filter. And so the dose to the patient actually hasn't changed that much as we've done the calculations. And so don't worry too much, because yes, you've just doubled, maybe tripled your technique that you're normally used to. And that might be scary to some technologists. But understand that A, you're still doing this for their benefit. So even if it is a little more dose, that's okay. But two, most of that dose is getting absorbed in the glass, so it's not too bad. Now, the beam, when you are super far away, the farther you get out, obviously the beam keeps diverging. But when you get all the way out and you collimate in, long SIDs make the beam more parallel. In other words, the divergence, really, the farther away you get, it's more straight on into the patient. And so this is actually a good thing. It helps reduce a lot of the geometric distortion, and it can help reduce the dose to the patient. Remember, the intensity is now going to be more uniform across the field of view instead of that heel effect. The heel effect is largely gone at very long distances. So dose-wise, it's a good thing. And geometric distortion, so yes, you're imaging at weird angles, but the distance factor will also help so that the edges are going to be not as bad, and just the image quality will be slightly better in some ways. All right. And then because we are imaging through glass, which is a very strong filter, this has that effect of reducing the overall soft tissue bone contrast. And so it actually will help you see the lungs better because the ribs will somewhat dissolve into the background. So there are some positives if you can find them, if you can consider them that when you're imaging through glass doors in these crazy COVID situations. So what do we do about folks that are in the room that are assisting, the nurses and whatnot that are helping? We need to help them feel comfortable being around radiation. So there's a couple of ways to do this. One, you can have them put on their normal lead aprons. You could hand them through. They would put the lead aprons on over all of their PPE. Then they can be in the room and feel comfortable. But when it's all said and done with and you need to take that back, it has to be completely cleaned. The other option is you can have a mobile unit, a mobile shield that you can just wheel into the room. You just put it in the corner, and this will be something you just take with you to all the different rooms. It obviously has to be sterilized after every use, but you could wheel it in. The nurse can help get the patient all set up, and when you're ready to beam on, they would just go stand behind the shield. So they don't have to worry about putting on or off lead. And if they have, the PAPRs and the respirators and all this other gear on them, because some of them are just, it looks like they're in a biological war zone, they might not actually be able to get lead aprons on. The worst case scenario is that the worst case thing you could do, if they can't put lead on, if you don't have a rolling shield, then they just need to get as far back as they can. So they get the patient aligned and they just step back as far away from the patient as they can, and they'll be okay. Scatter comes off the patient. We all know that, right? But remember, scatter tends to come back towards the X-ray tube. X-ray tube sends the scatter, goes in, interacts with the patient. A lot of that scatter comes back towards the X-ray tube, and then some of it will scatter out laterally. And so if the nursing staff or anyone's in the room, if they just get all the way back and away from them, there's very little scatter will get to them. So nonetheless, all PPE that goes into those rooms have to come out and they have to be sterilized. Luckily, those lead aprons and these lead rolling, obviously they're covered in plastic, so we can pretty much sterilize them without much of a deal. Now, what about you in the hallway? If you're imaging through glass, the glass is going to cause scatter. So the radiation beam goes through, yes, but there's going to get a lot of back scatter. So for you are going to need to be away. So step back as far as you can. Wear your lead. If this person just took this picture for the publication, so they weren't actually all leaded up. In fact, I don't even know. They may not wear lead, but for the most part, if you're standing within 2 meters, you should probably wear lead. If you can step back farther than that, you're probably okay. But get away from the X-ray tube because that's where all the scatter is going to come back. All right. The obvious benefit of imaging in this situation through a door where all of the individuals that are sick or infected are behind a glass door is that the system itself will not need to be sterilized as much. The sterilizing wipes and stuff that we've been using are very harsh. In fact, for us, having had to wipe down all of our portable detectors, we had to replace every one of our detectors because the cleaning solution actually corroded the battery and destroyed the battery on all of them. So that was a really expensive mistake. And that's why we bag everything now instead of just placing the detector directly in contact with the patient. Obviously, by imaging through protocols in a very busy situation where you're going from room to room to room, you don't have time to sterilize the machine and let it sit for 15, 20, 30 minutes. You have to be able to move and take the detector from room to room to room. And so imaging through with bags and stuff really helps you keep the equipment online longer. And then, of course, you being out there, if you're not going in and out of rooms, you don't have to take off and put on new PPE every time. And so it actually helps the hospital in general. So that PPE can be used for those people that do need to go into the room. All right, so we talked a little bit about motion. Due to increased exposure time for high mass techniques, there will be more involuntary motion on sharpness. That's just kind of part of it. We want to reduce the SID as much as possible, and this will help keep remember, when you got magnification effects if the patient's off away from the detector, and then the farther away you are, you're going to get that penumbral effect. And so you want to try to do your best to keep the detector as close to the patient as possible and try to keep your SID as good as you can, the source to image distance roughly in that, 140, 150 to 180 centimeters, whatever that range is that you're imaging. Breath holds, can you do it? Probably not. If the patient can hold their breath, I mean, we know that it's very short. It's less than a second to acquire the image. But for some patients, that might be an eternity. And so you may not get a good breath hold. But you do still want to get as much of a breath hold as possible, because obviously that expands the lung cavity. It puts air into the parenchyma, into the lung tissue, so you can actually get a nice, good image of the lung parenchyma instead of it being collapsed on itself, which makes it more dense, which makes it more white instead of black. Some patients are on ventilators, and so the nurse can, and in this case, you're going to be in the room imaging down. But in that case, the nurse can actually manually pause the breathing for a split second where you acquire your image, and then they can turn it back on. So you can actually get an artificial or a manual breath hold. So let's talk about artifacts that come from imaging through the glass. There are some glass windows that will have privacy barriers built into them, either shutters like these, or maybe white cloth blinds that'll come up and down. This is an example from this publication where theirs have basically collapsing shutters or blinds like you see here. Imaging through that, there's nothing you can do. But if the radiologist asks, now you know why there's these white lines through the patient, because those are the shutters or the blinds going through. A lot of doors will have these metal meshes in them. The glass will have metal meshes in them. Those are fire hazard or protections for fire hazard, for fire safety. And when you image through them, of course, you're going to get these star artifacts, kind of pretty. Unfortunately, they cover up the patient's anatomy. The best thing you can do is get your X-ray tube as close to the window as possible. Put it almost in contact if you can. Because basically what you're doing is you're just trying to make those patterns bigger on the X-ray itself. And here you can see, this was two different patients, but the same window. One was where the X-ray tube was a little farther away. The other one was where it was almost in contact with the window. And you can see the artifacts are largely gone, if not just barely present. All right, so that is if you're imaging in still a hospital scenario where it's probably still ideal, or at least more ideal. There's a lot of these field hospitals being set up in gymnasiums and conference centers, big convention centers. Your parking lot of your hospital might have a big hospital tent in it. So how do we image in these situations? So radiation protection principles. The best we can do is try to still maintain about a 2-meter distance from the X-ray tube and the patient. So as you're imaging, that's where all the scatter's coming. As the radiation's coming out of the tube into the patient, and the patient is causing scatter out. So if we can create a safe buffer of about 2 or so meters, you're minimizing the amount of scatter that will be incident upon any of the other staff or patients there in that area. So for mobile X-ray units, we're going to maximize collimation. In these situations, usually if you're going, if we're in this kind of a situation where you're literally rolling from room to, or setup to setup to setup, they're not really rooms, you will actually not be shooting through anything. It's not an image through protocol. And because of that, you can set your lighting and your collimation very good, because you should be able to get pretty close and get within your normal techniques. So maximize, do your very best to collimate, because the better the collimation, remember, less scatter comes off. Obviously, everyone should wear lead. And then, as I said, if you can get people to step back or do your best, you'll minimize how much scatter will be incident upon everyone around you. Now, there are cases, and some of my colleagues in other hospitals, they did this, where they set up the tent and there was one room basically for X-ray. And what it was as a portable system set up, and the system was stationary. And they would bring the patients either on wheelchair or in their bed up to that location, up to a wall. They would image through, and then the patient would leave. So we're talking about a quote unquote fixed unit, even though it's a mobile system. So what you want to do is, first of all, you need to make sure the access to that room is controlled. Obviously, it's a radiation and producing equipment. You don't want anyone to walk in. You definitely don't want anyone to think they can acquire images. Only technologists should be doing this. So that's a safety issue. If you have the choice, you want to use plexiglass instead of glass. So use plastic for your barrier. Plexiglass does not attenuate radiation. Oh, there they are. I'm sorry, my slides are out of order. I'll go back to that last slide. Plexiglass doesn't have as high an attenuation profile as glass. So for the same KV, or for the same amount of photons to the detector, you can use a lower KV, or you could use a lower KV and a lower MA. So imaging through plastic, you won't necessarily need to dial it all the way up to 130 kV. You might only have to go up to 110, maybe 120, but your mass might not have to go up to 12. It could be maybe 8 or 6. So sorry, my slides are a lot out of order there. Whoops. Okay, let's go back to my slide. There we go. So image through plastic if you're setting it up where you will be able to control your imaging environment. You may need to make sure you have a separate power supply for your portable. As people are coming and going, they have the overhead lights, they have all of the equipment, ventilators, whatever's going on in there. That might be a very taxing environment on the power supply. So it might be intermittent. It might have spikes and peaks and valleys. So if you could set up your own power supply, the portable scanner will actually perform better having its batteries fully charged and being able to consistently image. And then I just, a 20 to 35 kilowatt generator would be more than enough to power your 10 kilowatt X-ray tube. You obviously need to set up a connection, a Wi-Fi connection or something, so you can get the images to PACS. Infinitely better than having to burn them a CD and walk across the street. Okay, yep, looks like that's everything. All right, so an unideal environment can still be, you can still operate because you are trained, you're highly intelligent individuals, and with just a few modifications, you can stay. I personally believe you can still image fairly safely because you're doing imaging through, and you can still acquire decently good images. You just have to work with the types of artifacts you may encounter and some of the other issues, such as a little bit higher technique factor. So I guess we can just turn it over to questions if people have any.
Thank you so much, Sam, for giving us some aspect for the physics. How can we adjust the parameter on the KVMA? And also, you mentioned about we should take off the filter that we already have because we have a filter in the environment, so we don't need a filter in the machine. So this is a good thing to know. Let's see. So we also have Dr. Vivatana. You guys have met on the IR session, and actually he is a chest radiologist. So he is the one who read a lot of a COVID patient, I guess, and exposed with the COVID patient and the situation in the southern part of Thailand. So สวัสดีค่ะจันเน่ง
สวัสดีครับ Hello Sam.
Hello again.
Hello again, yeah. so อาจารย์เหน่งคะอาจารย์เหน่งมีคอมเมนต์หรือมีอะไรเล่าให้ฟังเกี่ยวกับสถานการณ์ของทางมอไหมคะของโควิดว่าในโรงพยาบาลสนามหรือว่าอะไรเนี่ยมันมีปัญหาหรือว่าทำอะไรที่ทำไอ้พวกนี้บ้างไหมคะ
Okay.
I asked Dr. Vipathana to tell about the situation in the southern part of Thailand and in his hospital, what he is doing right now.
Wonderful.
Yes, Thailand right now we face with the third wave of COVID pandemic, which is much which involve many patients more than the first time and the second time. During the first wave and second wave, we had enough beds in the real hospital for the infected patients, but this time we don't have enough for them. So we need to select the patients, which one for the real hospitals, which one for the field hospital.
Mm-hmm.
For the field hospital, usually the patients are asymptomatic and we use chest X-ray to manage. We don't use X-ray for detection or for diagnosis, but to manage the patients. So the patients who are asymptomatic and negative chest X-ray, they will be referred to the field hospital, something like that. And chest X-ray, chest radiographs are done not every day, but very often for the mild patients to make sure that there is no lung involvement. And for the COVID-19, the early lung involvement, the radiologists they need to observe the lung markings, the lung vessels very carefully because early infiltration will make those lung markings blur, something like that. But I find that most of the radiographs from the field hospital, the sharpness of the lung markings are not so good. So sometimes we need to repeat many times, many before making sure that there is lung involvement.
Mm-hmm.
So I would like to I think the patients in the field hospital we don't expect to see big things in the chest. We would like to see very subtle, very faint findings, very subtle increased attenuation in the lungs by observing the sharpness of the lung vessels, something like that. Mm-hmm.
So อาจารย์คะ so what technique do you use at the field hospital? Do you your technologies increase the kV and adjust the MA level as well, or do you know?
No. I don't because we are radiologists. Sometimes we don't know. But this is I observe that this is the problem. So maybe we need to explore, or maybe we need to would like to hear your comment that what point we need to focus on, or to evaluate, or to explore. Maybe they don't use grid. Maybe they don't use grid as you said, or the KV they use, something like that.
Yeah. So if they're if you're imaging in the field hospital, they're asymptomatic, therefore they're probably ambulatory. I'm not certain if you guys have set it up where the question was, how can we improve imaging, especially in the field hospital where we're looking for subtle findings.
Yes.
In this case, these patients, as you mentioned, are asymptomatic. So they're most likely ambulatory. They're probably people we can talk to. We can ask them to hold their breath. So we can image them in an ideal situation. Now, I don't know exactly how you're doing it, if the mobile unit will come to them or if you've set up one location and they'll go to it. But if you do this, I highly recommend using grids because you can set it up so that the patient are either seated or they're standing erect, and you can get the grid in a good location. You make sure everything is perpendicular. you remember as close to the detector as possible so that we can improve the spatial resolution. If we are off, remember the magnification, we get an anatomy that's magnified, but we also will blur the edges of the anatomy. So the closer we get the anatomy to the detector, the better. Good collimation obviously makes for the gray-white imaging. But here, what I'm hearing from you is you really want to see the subtle, the vessels, and you want to get good resolution. And so my comment is make sure you got a good grid in. The technique factors will be just your normal technique factors because you're not imaging through glass. I'm guessing you're not, and you're probably not imaging in any weird situation. It's just a normal, they might be in a bed, they might be in a chair, like a wheelchair. So go back to the basics, the fundamentals.
To the basic standard. Because patients in a few hospitals, usually they are young. This time, they are young and asymptomatic. They can help themselves.
Yeah. So in that case, it might be helpful though in the field hospital to set up one room for imaging. So the mobile unit will be stationary. The patients will come in, and it's something where you can control you can keep the infection rate down because you can wipe everything down. But what you could do is you could set up a holder for the detector. So they just walk in, they hug they'll hug the detector like they normally would. You get the image and then they're done and they can walk away. And you don't have to worry about repositioning. You don't have to worry about the grids coming off. If you can get it set, then they just walk in the room, you get the image, they leave, and you sterilize everything, bring the next patient in.
Like a normal situation.
Yeah, except for with a portable unit. Yeah.
Thank you.
Yeah, no, and good luck. Thank you for all you're doing.
So there is like the questions about the things that Dr. Vivathana comments on, that we want to look for the sharpness on the fine details of the lung parenchyma. So is it better if we use a small focal spot to increase or improve image sharpness and reduce penumbra?
Yes. In this case, because unless it's a really big patient, we're not imaging through glass, so we don't need to change our KV real high, and we don't necessarily need to increase the MA real high. And if we don't have to have a real high, so if we have a 2 or 4 mass, then we can usually use the small focal spot.
I see. อาจารย์ปานฤทัยมีคอมเมนต์ไหมคะไม่มีค่ะ Let me see if we have any other comments on the chat box. So I think like right now the situation in Thailand, in field hospital, mostly the patient can walk. Yeah. So it may be easy to do stuff, but the issue is in the hospital that we need to do like a 2 glass technique or like an isolation. And the issue is in Thailand, in some hospital, we have only 1 or 2 technologists.
Oh, yeah.
So that create an issue that they need to work maybe almost like a 24/7, and they need to protect themselves with the lead aprons and also the PPE, which is really heavy. And the weather in Thailand is very hot.
Yes.
So yeah.
Yeah.
Any comment?
So I don't know exactly how your ICUs are situated, but if they have the glass doors so that the rooms are cut off from the patients, obviously they're in their PPE. But if there's enough room in the hallway, they can set it up, and then they can step back. If they can step back 2 meters, then they won't necessarily need to wear lead. Now, I make that statement. I don't know what the laws are in Thailand. In the US, we have specific laws that say we have to wear lead. And so our technologists have to wear lead, even if they step 2 meters back. If there is no law in Thailand, then maybe what they do is they just sit it up and then they step back and then they pull the trigger. And as long as they're far enough back, they will be fine. Scatter will not be a part of that. And at least they won't have to worry all that lead all day long, because that is really heavy.
Yes. Any comments from the audience who is a technologist on the situation or any issue or any questions that you want to ask? Dr. Samuel, ready? No, it's very clear.
Yeah, unfortunately, everyone's just living with this situation.
Yeah, we just need to adjust. Yeah, on this.
Yeah, you know, you technologists are wonderful, and so you're doing a very difficult job in a very difficult situation. You know, obviously being uncomfortable wearing lead and PPE all day long, you're around sick people. So, you know, I'm so grateful for the technologists. They're amazing.
Yeah, we are so grateful for them, and we are so lucky to have technologists to help us taking care in this process. Yeah. Okay, so I think we are done for today. อาจารย์ปามีคอมเมนต์มีอะไรเพิ่มเติมไหมคะหรืออาจารย์เน่งมีอะไรเพิ่มเติมไหมคะก่อนที่เราจะปิดเซสชันวันนี้ Okay. So thank you so much, Sam, for giving us an idea about the imaging technique optimization in DR and CR, and also how to integrate the physics knowledge in the unusual COVID situation that we are facing right now. So thank you so much. And next week we still on the CR and DR technique. Then we are going to talk about the dose optimization, right?
Yep.
The dose metric, and also how to set up the dose alert level on the DR and CR, right?
That sounds good.
And as usual, so after this talk, we're gonna send a link, this evaluation link for the people who want to get the CME credit, and we want to hear the feedback from you. What can we do better, or what topic that you want to learn more? And please complete the link by Thursday midnight, and on Friday you will get the CME certificates and also the link for the next week. And we're gonna meet again next week at 9 a.m. and hopefully the COVID situation is getting better. So please wash your hands, social distancing, stay home, and be safe. And I also would like to thank our sponsor, the Bayer, GE, and Philips to support this educational course during this difficult time for us to learn about this thing. So thank you so much, everyone, and see you all again next week. สวัสดีค่ะ Thank you. Have a good night, sir.